technique works very nicely. Dr. Suven, please.
Right. Thank you, Professor Tijal, for this kind invitation. So we'll start with small pupil management. I'm going to talk about a few key issues. What I feel is we need to differentiate between a rigid and an elastic pupil. That's paramount. And we'll talk about IFIS and go on to the iris hooks and pupil expanders. So this is an elastic pupil, which is a typical IFIS pupil. And on the right is a rigid fibrous pupil, which is like a string. So try as much as you may, it is not going to stretch. What you can do is you can tear it, you can break it, but it will not stretch. Once we understand that, we go on to how to differentiate. So just inject, once you've created the side port, just inject bases from the side port, and that, when you inflate the antechamber, that little bit pupil expansion will suggest that it's an elastic pupil. And then you can go ahead with your device, depending on how much of expansion you have. So those were two. And now look at this pseudoexfoliation. It looks like a rigid pupil. So you go ahead and can you reset the timer, please?
No.
Yeah. So, and this is a total giveaway where you have ectropion UV and a small pupil, and there's no way you can stretch this. So, I mean, using a device to stretch it is not really a wise idea. A bimanual stretch and then putting even iris hooks would probably serve the purpose better. So, now this is one case with posterior synechia. So, where I would probably use spatula to release the synechia and go well under the iris and a few sweeping movements to release some total posterior synechia. And then you inject bases and see, well, I was not still comfortable with this, so we went ahead and tried to remove those membranes and see if it would work. Wasn't happy again, so we went ahead and did a stretch. Now, this stretch does not go from angle to angle or limbus to limbus. It goes halfway. So we want the pupil to come to about 4.5 millimeters, and then it would expand enough to accommodate iris hooks, pupil expanders, whatever it is. So look at that. Before stretch, not very much, 3.5 millimeters. And after stretch, we got about 4.5 millimeters, which is good enough to go and use a pupil expander. Something about IFIS is, now, this is a typical grade 1 IFIS where you have just undulatory movements, and it's not so much of a botheration. You can go ahead and do that surgery and get off with it. Just a little bit of movement of iris fluttering. And this is a very typical IFIS where nothing wrong with the fluidics. Very old videos, I'm sorry for the video quality, but the message is conveyed, and you, as the pupil comes down on you, the iris is prolapsing. Nothing wrong with your technique or the fluidics, it's just the nature of the iris. What we must remember is hooks or pupil expander do not guarantee against the prolapse of the iris, but they do ensure an adequate pupil size for the safe phacoemulsification. So if we go down further, now this is another case where I had used iris hooks, but despite that, by the time I finished my capsular exis, I had an iris which looked most like a fishing net, and I'm struggling over here, the iris popping out through the side ports at every stage. But because I had iris hooks in place, I could get away with this. And you see, even when I'm injecting that IOL, I'm trying to support that so that I do not have an iris coming into my nozzle and causing an iridodialysis. So next. Now, this is the list of predisposing factors for IFIS, the drugs and the systemic conditions. That leaves us with hardly anything. So no amount of history taking is foolproof, so we better brace ourselves for IFIS with every case. So the current knowledge tells us that there is pharmacological inhibition of the iris dilator smooth muscle, which causes meiosis, and there is a long-term damage to the muscle by degeneration, which causes the floppiness. And of course, there are drugs which get stored in the pigment granules, and that tells us that there are n number of systemic drugs which can cause floppy iris, apart from the alpha antagonists that we know of. Now, this is a publication in AIO. I would urge you to take a look at this. Excellent work, a large study, and it tells us that the incidence of IFIS is higher in India, and as we know from literature, tamsulosin, alfuzosin, and hypertension are important risk factors. A few takeaway messages for IFIS. Like I said, a host of systemic conditions, so history taking is not ever good enough. IFIS can occur on patients with pupils as big as 7 millimeters, so you may be surprised. IFIS can occur even 1 year after stopping tamsulosin. IFIS can occur within 3 days of starting tamsulosin. And stopping tamsulosin of really no value now. And women may be on tamsulosin often for UTI. So when you come to mechanical dilatation, like I said earlier, we need to differentiate. If it's going to be an IFIS pupil, no amount of stretching is going to help. In fact, it can be counterproductive. But for a rigid pupil, it works well. So we have the iris hooks, and we have the pupil expanders, honestly, I don't know of any other pupil expander other than the B-Hex. But then, for the record, it's the mulligan ring also. But yes, so iris hooks, a few basic things. We make the side ports first. Visco, do not want to overfill, and a little clear canal incision directed posteriorly. And I would like to leave a small conjunctival mark with a small bleed over there, which helps in localizing that place, otherwise it gets quite embarrassing. Retract to the stopper well in advance so that you're not embarrassed, and you hold the hook sideways, and you do not pull the hook all the way, just mid dilatation of the pupil, so that you can adjust your dilatation, and you really don't need a fully dilated pupil. So capsular rhexis should be as per your plan. Don't get carried away by the extra pupil expansion that you have now, which can actually be harmful. And remember that the pupil margin is anti-flexed, and the pupil margin is elevated to the limbal plane now. So every time you put in an instrument, you have the risk of damaging the iris. So taking out isn't very difficult. Hold the stopper and advance the hook, turn it sideways, and pull it out, and just turn it a little sideways, and it straightens momentarily and comes out. No damage to the cornea over there. Yes, there it is, and you just turn it, and it comes out. This is the rhomboid pupil. You can have a sub-incisional hook, which helps in not having an iris prolapse through the main incision. Now, a few more pearls. Now, I would look at this. This is a small pupil, and I started with over-retraction. Now, no way I could stretch this, so now when I'm going to put the third hook, I'm going to have a huge rip in the sphincter. And that is horrible to look at post-op. There I go, and there I have caused a huge sphincter tear. So I would have probably, it'd been wiser I'd stretched it a little bit, and then, or use those hooks gently and not pull them all. Now, if you're going to do after capsular rhexis, you just tent the iris with the spatula, and you'll be clear of the capsular rhexis margin with the hook. And then you can put, the next hook can come just under that, and you get the plane over there. So there are certain disadvantages, but what to me the most important is that there's a lot of wasted space over there which we're not using outside the capsular rhexis, which is there with the iris hooks. It can leave a bad mark in the post-op period, and like I showed, a sphincter tear also. This is the Hex Pupil Expander, and like I said, it's, I think, doing well now. It's a lot thinner than the available expander. It's got 6 notches and flanges, and comes preloaded. You just need to hold it, the leading flange, and advance it into the antechamber, place the device into the antechamber, and then start tucking alternate flanges under the pupil margin. There goes the first flange under the pupil margin, and that's the second one, second alternate. The ones, they got holes on alternate flanges for easy identification. And the holes are done, don't serve any other purpose. And it's a uniplanar device where the iris actually bends at the notches, and the device is in a single plane. That's how it differentiates. So removal is very easy. Just disengage 2 notches and pull out 1 flange, and it just walks out. And alternately, it can be even removed through the side port, 1 millimeter side port incision, which is very helpful in a shallow antechamber and a tight situation. So that's the difference between the mulligan ring and the B-Hex. Like I said, the pupil margin straddles, and the device is uniplanar. That makes the device very, very thin, and the other devices are much bulkier, and they come in the way of surgery. So this is a real device in work, and what's important is that it's very easy to insert and remove, especially in shallow anterior chambers, and there is no learning curve because it's just a forceps and take it into the anterior chamber. And there you are. You tuck in the first flange under the pupil margin, and then the second one. You could use a side port instrument to just stabilize the eye and give counter force. And here, there it is under the pupil margin. And removal, like I said, you just disengage 2 notches, hold that flange, and draw it out, and it just walks out of the incision. And like I was mentioning, no device can really come out through a side port, but the B-Hex can, and that is wonderful to watch. And you leave a wonderful round pupil which looks elegant on the first post-op day. A few pearls, but most important is when you're delivering the lens, you need the lens, the trailing haptic, to go into the bag in the single pass, or you need to take care that you don't dislodge the ring into the bag, where if you push, don't push the trailing haptic, you guide the trailing haptic beyond the capsular rhexis margin. A couple of publications, and that's my last video over here. So after capsular rhexis, if you want to use the device, this is probably one of the safest devices. Here we have intraop meiosis, and This is when we are struggling, and now we decide to inject a little bit of viscoelastic under the pupil margin and create that little bit of gap over there between the capsular rhexis and the pupil and the iris, and we tuck that flange. As we tuck that flange and advance it to the periphery, we have instant confirmation that we have not engaged the capsular rhexis margin. Otherwise, we would have felt resistance. And that's how we do that again, and tuck it under the pupil margin and advance it, and you have instant confirmation. And once that's done, and the third flange is tucked under the pupil margin, you are again back to comfort zone. And that is easy. Thank you very much for your kind attention. I invite you to Kolkata for the next AIOC, and not for the discount, for the rasagollas. Thank you very much.
Beautiful presentation. We are proud of your achievements and
Thank you, sir.
innovations. Thank you for being part of this IC.